welcome to our first news conference of ENDO 2023. We're very pleased to have you with us here in Chicago, Illinois. My name is Jenny Glenn-Gingery. I'm the Director of Communications and Media Relations for the Endocrine Society. Today's news conference will focus on reproductive health research. We're very pleased to have with us Dr. Terry Fultonen, Dr. Chana Jayasana, and Dr. Poon Kembagoda. Over the next 30 minutes, each speaker will present their findings, and then we're going to end with a Q&A session. Please note that a number of journalists have joined us on the live stream. So because we are broadcasting live, it's really important that any remarks be made into a microphone that allows everyone who's joining us virtually to fully participate. Journalists who are attending online, you can type your questions into the chat at any point during the news conference, and we will address them during the Q&A. I would now like to invite our first presenter, Dr. Fultonen, to speak.
Thank you, Jenny, and thank you for the invitation to have this talk and talk about this important finding from our data set. So this is polycystic ovary syndrome and the association with increased mortality risk that we have found in our birth cohort that we are working on. I do not have any disclosures. So, as many of you know, this is the most common endocrine disease or trait in reproductive age women, and women are burdened with a high risk of other comorbidities, decreased workability, and early retirement. I will throw that into details soon. The morbidity risk has been identified, especially for metabolic diseases, psychological distress, decreased lung function, and musculoskeletal diseases. And this picture is from a work from Australian colleagues that have shown that, for example, diabetes risk increases earlier than with other women. So the problem in many cases is that women with PCOS are burdened with obesity, so about 50 to 70% of the women are obese, and this we have also shown in our birth cohort that does not specifically target women with PCOS. It's an actual birth cohort that women are born into this, and we have shown for the first time that the women start gaining weight already before the age of 5, during the age of adiposity rebound, that is actually earlier for these women, and after that the women end up having higher BMI at age 31 and 46 where we have assessed them. And what else is there is that the women themselves claim that they have poor self-reported health rate compared to other women, and also when we were looking at the increased morbidity risk for different disease states, we're able to show that they have up to 35% increased morbidity in this particular data set. And then if you look at how this accumulates, it does not actually accumulate with obesity, so it also, there is some setting I think here, so it actually accumulates also with the normal weight women, as you see in the red area, and then the fact that they also have increased risk for disease and medication in this data set points out that it's an important condition to recognize. And we have also further shown that they have decreased workability when they support themselves, and then some of this disability actually seems to be related to disease burden. And then we were looking at this accumulation of, I'm sorry, there is some can we change this or not? Can we change the setting? It just moves on. Sorry, it just keeps on moving. Well, let's just try to go like this. But anyway, so they have increased a rate of early retirement at the age of 40, and we were quite surprised about this finding. Now, whether this accumulation of multimorbidity leads to increased mortality is actually quite unclear. So to investigate the overall and cause-specific mortality in women with PCOS, we utilized the Finnish National Registered data set. And here you'll see that we use the care register of healthcare in Finland. This covers all people in the country with and all the people persons have been identified with the personalized identification number. And we're able to pick up the women with PCOS with the ICD codes, and then we also link them to birthplace, educational level, and cause of death. And this is the study population, so the registered data includes about 10,000 women with PCOS, and then birth year and residential area matched controls. And And this is one of our background findings. So the women with PCOS, the mean age of the diagnosis was about 27 years, which is in line with other studies in the field, and the median follow-up time was 13 years, and the median age at the end of the follow-up was 41 years. And then about the result. So here you can see that the mean age of death was about 1 year earlier for women with PCOS, giving about a 54% increase unadjusted hazard ratio for mortality, and with the education adjusted value of 1.48. And then we went to a different, like what is behind the different, the differences between the different groups, and we're able to see that cancer, endocrine, nutrition, and metabolic diseases, and also diseases of the circulatory system were increased and explaining this finding. And then we corrected this for education, and still the cancer rate and also the disease to circulatory system mortality remained significant. And here are the survival plots for death and mortality due to cancer. And then we went and tried to pick even more specifically what's inside in the data set. So in an adjusted analysis, the colon cancer seemed to be increased. Also other diseases of circulatory system, you can see in the below that this means hypertensive disease and pulmonary embolism, etc. These are the non-ischemic heart diseases. And then bronchitis that can also relate to, for example, pneumonia. And then after adjusting for education, we're able to see other diseases of circulatory system as well as diabetes were the causes. And interestingly, the colon cancer did not survive this analysis. And in summary, women with PCOS seem to be having increased mortality due to diseases of circulatory system and cancer as well as diabetes. The good sides of this, or the strength of this study, was matched controls, age and place of birth, as well as the data was adjusted for education. And this is actually shown to have an excellent proxy for socioeconomic status in our country. The free healthcare system and good accessibility seems has a good background in this data set. So the healthcare does not change according to your socioeconomic status or where you or residential area. We have shown earlier that these registers are reliable. The downsides are that there is no possibility to assess for BMI. We do have a small data set here where we have pre-pregnancy BMIs, but it might be that we are then underpowered for the analysis. And then, of course, we did not have any access to phenotype data, and then we have a fairly young cohort, so we need to see what happens in the long run follow-up. And then, of course, in Finland we do have a quite a big majority of the population are Caucasian, so of course the ethnic variation was not it was not possible to assess it in this study. So thank you.
Thank you so much, Dr. Fulton.
Very interesting.
I'd now like to invite Dr. Jason to present.
To present our data today. Okay, so I'm going to start with really a summary slide of actually what we've shown. So in men who take anabolic steroids, we've actually performed the largest study of its kind, looking at hormonal recovery when men stop these steroids. And we found that when men stop steroids, you get a crash in testosterone levels, which produces awful symptoms. But men are actually self-treating them with drugs to stimulate and reawaken the testes, which is not recommended. Peculiarly, there's a fourfold higher chance we've observed of recovery when they do this, and to prevent hypogonadism. And we've confirmed several other findings which have all been reported, which make sense that the more drugs you take, the worse your outcome, and the longer you wait, the more likely you are to respond. So let me go into the details. So this is a group of drugs which basically are unified. It's a diverse group. They all stimulate the effects of testosterone. And in the 1950s, it was just used for elite sports people. It moved on to amateur bodybuilding, and now, unfortunately, most men take them just to look better. And we estimates are 1 to 5% of all men. It's really interesting. I think there are important societal changes all over the world. If you look at Luke Skywalker in the 70s and today, there are differences, and there are lots of role models of how being a healthy man has changed. And body dysmorphia, reverse anorexia, is endemic in our society, and social media has just made that worse. The effects of anabolic steroids, I'm just summarizing on a slide, can be coalesced in sort of behavioral. It can cause psychosis, violence in otherwise law-abiding, happy men. Can cause abuse of their partner. It can cause cardiometabolic problems leading to death. And also, as I'm focusing on today, gonadal problems. It switches off the testis and causes hypogonadism, erectile dysfunction, and infertility, asospermia. It's very difficult to give up steroids because you get psychological dependency leading to depression and suicide risk, body image dependency because they're worried about losing muscle bulk, and physical dependency because they have no erections, and a lot of them are bedbound. So this is a summary of the reproductive axis. The hypothalamus drives the pituitary gland to release hormones stimulating the testes to make testosterone and sperm. And what steroids do is it switches off like a light bulb everything. And when these men stop, they feel awful. And what that does is, it's no surprise, it makes them want to restart anabolic steroids. And this is a cycle of dependency and abuse. Now, as I said, there is no guideline out there, no help out there to actually help these men. We simply wave a finger at them and say stop, which isn't very helpful for a lot of them. And so what they're doing, this is not advised at all, I want to stress, is that they're looking up on the internet recipes for these drugs, which are well known medically to actually treat people with infertility, to try to, when they stop steroids for a few weeks, actually boost and switch on their testes in the hope that this will help them in the absence of any evidence, so it's unproven. And actually, we're concerned this might actually make the problem worse. So no one's ever looked at this before. So we did a retrospective analysis of a large clinic in Glasgow over 7 years. Glasgow has an enormous social burden. It's huge rates of unemployment and substance abuse. And nearly 700 men were studied who'd stopped steroids in the last 3 years. And the majority of them had taken what we call PCT, post-cycle therapy. That's the name, the umbrella term for these hormones to try to wake up the testes. And I stress they bought them illegally. And the reason we can do this study in England and not in many other countries is these men will not be arrested. It is it's illegal, but they will not face criminal prosecution. So there's a good border and interface with the healthcare system. What we found initially was that the red line shows what happened to people who took these drugs to try to switch on the testes, and the grey line shows what happened to those that didn't. And we could see that there's a slightly increased likelihood of having normal LH, FSH, and testosterone, the 3 reproductive hormones. And on the right, we can see if they were all normal, it seemed to happen slightly sooner in the group that took these drugs. Now, there are lots of variables like age and the amount of drugs you've taken, so we did what we call a multivariate analysis to try to look for independent variables correcting for these factors. And just looking at the top, I put helpfully green means good, red means bad. And if you look, then people who took these drugs had a nearly 4-fold higher likelihood of achieving normalization, recovery of their gonadal hormones than if they didn't. But this was restricted to people who'd stopped steroids in the last 3 months. So it means that if people are using them, it appears to have benefit within 3 months of stopping, but not beyond that. And again, I won't go over this other data, which I've already summarized, but this has already been covered, that clearly if you wait longer, you're more likely to have recovery. And if you take more drugs, then that's bad. And so taking a single anabolic steroid drug is better. So just to summarize our findings, we've shown for the first time in an observational study that men who take these DIY drugs to try to switch on their testes for an unknown reason have a fourfold higher chance of biochemical recovery, but only if they stopped anabolic steroids in the last 3 months. And other factors are also associated with biochemical recovery. Now, clearly, there's scope for a call and recruitment bias. Maybe men are more health conscious if they take these DIY drugs, and they're more likely to present. So that could be a confounding factor. We did random blood sampling, but this is best done when actually you have fasting morning samples. Otherwise, you will overdiagnose low levels of hormones. And also, there's the problem of concealed drug use, although recent data has shown that 80% of the time, these men tell the truth. And also, these are counterfeit androgens and PCT drugs. So this is the opposite of a controlled study. But nevertheless, it's an important study. What's our take-home message? Men taking drugs which stimulate the testes, when they stop taking steroids, are more likely to recover testicular function. We now want to know why. Further studies are needed to prove causality because ours does not. But if proven, we could be on the start to a goal of actually helping millions of men who want to stop steroid addiction. Thank you.
Thank you so much, Dr. Jayasena. I'd now like to invite Dr. Kempegowda to present.
Thank you. Good afternoon. Thank you for this opportunity to present our work here. My name is Dr. Punit Kempegowda. I'm an assistant professor at the University of Birmingham, UK, and also a consultant at Queen Elizabeth Hospital, Birmingham. And I'm going to be talking to you about body image concerns in women and individuals with PCOS and how we found what we found. To start off with, PCOS is the most common endocrine condition affecting 10 to 15% of women worldwide. Body dissatisfaction is a condition where people feel unfavorable or have negative feelings about their own body, and it can happen to men, women of any gender. Several studies have shown that women with PCOS have body dissatisfaction and body image concerns. So why worry about body image concerns? Having poor body image will lead to having low esteem, feeling low about themselves, developing depression, and that will, of course, reflect in their social and occupational working, and they may not be the most productive member of the society. Currently, most academic research focuses on either diagnosing PCOS or treating PCOS. Clinical work more so focuses on helping women to conceive or preventing them having long-term risks. What's missing right now is what's happening to the women now, the woman who's sitting right in front of you. What's their quality of life? How can we make it better for them? And this also comes from an anecdotal practice where things have shifted, where women were focused to come to the clinic saying that I'd like to have a baby, to now saying that I'd like to feel good about myself. And that is important. And this, I don't know how many of you are familiar with DC or Marvel, and I love this quote from Superman versus Batman, where Superman says to him, "You don't let me live, you don't let me die." And that's the feeling that women always come and tell me. So we need to start doing something to help them feel better. Although there are studies that show that there is some association of body image concerns in PCOS, we don't know how big the problem is and what it means to those who are affected. And that's where the study came from. So we wanted to know what is the currently available evidence to show that there is body image concerns, and if so, how big it is. And secondly, currently there is an ongoing process of updating the international guidelines for PCOS. So we wanted to inform them that this is our findings and we want to do something about it. How did we do? We looked through all scientific publications for any original study. It could be of any type, any shape, anywhere done, on body image and PCOS. So we use a system called PICO, which breaks down to 4 different areas. First is the population. So we wanted to look at any study which looked at women of any age, any ethnicity. In that, we wanted to see if there's a group which had PCOS and a control group which did not have PCOS. And the outcome we were focused on is, did they report anything about body image concerns using validated questionnaires? And that is important because we need to start understanding how they did it. The next couple of slides is an overview of how detailed we went to identify all the studies in various databases. We went through Ovid, Medline, Embase, PubMed, Sinhal, Central, pretty much every known database to man and women. And when we looked through all of them, we found 6,221 articles that met our criteria. A lot to sift through. We were able to remove about 2,000 duplicates. We still were left around 4,000 articles to go through. We were then looking at the abstracts, the initial bit of the paper. We were able to exclude another 4,000. Now, this is important because we needed two different researchers to go through all these 4,000 articles in depth to make sure they did not meet the criteria to exclude them. A lot of work put in. We were narrowed it down to 118. These 118 we further sifted through, and we read through the whole article, and we found that there were 77 which did not meet the outcomes or many other reasons. We did not stop there. We also spoke to experts about body image or PCOS and found that there were 3 other articles which did not show up in our initial search. We went through them, but unfortunately they had a different study design and hence not appropriate to our work. So after painstaking work of looking through 6,221 articles, we were able to find 9 articles that was relevant to our work. 2 researchers spent months of their time working through this, and if they had any doubts between them or if there was any conflicts, a 3rd researcher would look at that to resolve the conflict. So we analyze this work through a process, through a system called a review manager. It's one of the most acceptable way of analyzing or doing something called as meta-analysis. In simplest way, meta-analysis is a process where you take up the data that's already published, group them together, and analyze them together. There was some work which we could not meta-analyze, and we've reported them as a narrative descriptive way. But for the purpose of this talk, I'm going to focus on meta-analysis because what we found on descriptive work is similar to what we will report in meta-analysis. So to meta-analyze, we need to have studies which use the same type of questionnaire, a validated questionnaire. And the 2 most commonly used questionnaires were MBSRQ, the Multidimensional Body Self-Relations Questionnaire, which has 5 subscales. I'm going to go through each of them, and the Body Esteem Scale for adolescents and adults, the BESA, which has 3 subscales. To start off with, the first subscale of MBSRQ is appearance evaluation. It's basically how satisfied does a woman feel about their physical appearance, and low score is bad. Women with PCOS scored lower compared to healthy women. Next subscale is orientation, i.e. how much time they're investing in grooming and in their appearance and how they feel about themselves. High scores are bad. Women with PCOS scored higher, significantly higher. Third one is overweight preoccupation, how much they feel anxious about their weight, how much they are dieting and doing things to help lose the weight. High scores are bad. Women with PCOS scored higher. 3-on-3 subscales going against women with PCOS, not looking good. Let's go through the other 2. The next one is self-classified weight. How much do they think is their weight? What do they perceive about it? High scores are bad. Women with PCOS scored higher compared to healthy women. Last subscale is body area satisfaction, i.e. this is the degree of satisfaction they have about their face, their muscle tone, and various other parts of the body. Low scores is bad. Women with PCOS scored lower. 5-on-5 subscales of MBSRQ shows that women with PCOS have significant body image concerns. Now let's look through BESA. The first one is about appearance. Again, these scores are straightforward. It's a low score is bad, high score is good. It's generally about how they feel about their appearance. There was only 2 studies that used the scale, and we did not find a significant difference, and I think that's because of the low numbers. Second one is about weight, and despite the low numbers, there was a difference, and women with PCOS scored lower, meaning that they were not happy with their weight compared to healthy women. And the last subscale is attribution. How do they attribute to their one's own body and appearance? Low score is bad. We did not find any significant difference. So With BESA, it was a mixed report. We were not able to clearly differentiate, and this is also important because when we did the analysis, when we did the study, we found about 20 different types of questionnaires, validated questionnaires people have used for studies. But the importance of using a questionnaire which actually differentiates the findings is important, and that kind of highlights where we should be going in the future. So what do we find from this? So this is the first systematic analysis of body image concerns in PCOS, 2023, it's the first one. Diagnosing body image concerns might give us an opportunity to address patient concerns. It's about what they want, what they think about themselves, and this is an opportunity for us to work with them. If we help them to get what they want, then they'll start listening to us, and we may be able to get on top of other things like long-term concerns and everything. So as the second objective, we shared our findings with the international guidelines group who are revising the guidelines, and hopefully it should be out either this end of the summer or fall. And they recommended an individualized approach in terms of assessing for body image concern. And the main reason being resource implication, whether this would increase the length of consultation. Valid point, but this is where the image scales come into play, the validated questionnaires come into play. Even before the person comes into the consultation, they can complete this questionnaire, and it's an easy way of screening they have a concern or not, and then we can address it as appropriate. I took this picture yesterday when I was traveling through subway, and I love this quote: mental health or physical health, coverage is coverage. When insurance companies are thinking, it doesn't matter what you have, we need to address it. We as healthcare professionals, we need to start changing that. It's not just their physical health, it's not just their long-term concerns, it's not about risk of developing cancers and diabetes, it's about the person sitting in front of you. We need to address that, we need to help you, and that's an important message I got from this. There are some limitations in our work. So, there was a lot of heterogeneity, i.e. the studies we included, the 9 studies were of different shapes, sizes, used different questionnaires, and that might limit the way we found the results. The number of women that were included in the studies were also low. However, the studies came from all parts of the world. We had studies from Middle East, South America, Europe, Asia, which kind of gives a saying that this is not just a first world problem. Somebody made a comment very recently saying that this is woke medicine. We can't just be addressing everything about everyone. It isn't. It's not a first world problem or a Western world problem. Everyone, everywhere in the world are having this concern. So it's 10% of the world, 10% of the women in the world, even if you take conservative estimates, that's about 1 billion women. That's a lot of women who are affected with this. So where do we go from here? The first step is to identify there's a problem, but that's not where we stop. We want to know what's happening beyond this. How exactly is it affecting? Is there a role of ethnicity, deprivation? Is it because of the peer pressure? Is it because of social media? And one of our fourth year medical students, Sophie, she's just got a grant to look at this in a little bit more detail, to talk to women of different ethnicities, different deprivation scores, different places in the world to understand what they are experiencing and why is it happening. Further, we will then understand how this is affecting their lived experiences, how it's affecting their daily, day-to-day lives. And another medical student called Ella in our university is going to look at this in more detail. Thirdly, one of the things people say is it's because they have too much of weight. It isn't the case, because hirsutism or excess hair can also make them feel uncomfortable with their own body perception. And that's another thing that we will be looking at. And as you might have already picked up with the theme, this will be another medical student. And the idea here is to try and involve the medical student as early as possible, start striking their thinking brains up so that we can have future leaders also. It's a win-win situation. And finally, we want to understand how clinicians and healthcare professionals across the world are assessing body image in the world, so we can start to put together a simplified way or a standardized way so everybody can assess this in a similar way. And that is important because that will mean we can address that heterogeneity problem that we found, and we can have a common denominator to find all the concerns that's about body image. And lastly, we want to teach and educate wider medical population, and we are organizing a meeting called Repro on the 27th and 28th of September, which is the PCOS Awareness Month, where we will be talking specifically about PCOS and body image as one of the cases. In conclusion, body image should be assessed and managed appropriately in all women and individuals with PCOS. We need more studies and more standardized way of assessing body image so we can start putting the, information together, not only to diagnose but also treat appropriately. I'll end the talk, this is the penultimate slide, with a quote from William Osler, who is the founding physician of structure-based teaching, bedside teaching, and he said, a good physician treats the disease, in this case PCOS, a great physician treats the person with the disease. Of course, we couldn't have done any of this without teamwork. We had everyone, all hands on the deck. We had medical students sifting through that 6,221 articles to find what is appropriate. We had early career researchers trying to resolve the conflict. We had mid-career researchers helping us with analysis and finding the best way to represent the results. And of course, senior researchers like Elizabeth Steiner-Victorin from Karolinska and Helena Teed from Australia, who was also the chair for the International PCOS Guidelines, trying to help us to make meaning out of it and trying to incorporate into the guidelines. With that said, I thank you again for the opportunity to present and listening to us. Thank you.
Thank you so much, Professor Kapagawanda. We're going to go ahead and open up everything for Q&A now. If anyone in the room has any questions, we'll start with you. And if you are viewing our live stream, please go ahead and type those in the live chat, and we'll get to you in a moment.
Thank you. Wonderful presentations. Sasha Ati from PCOS Challenge. For Dr. Punnett, the last discussion, can we look a little more upstream into why body image or why there's such a huge difference between PCOS patients and non-PCOS patients with body image? Could it potentially be how we or healthcare providers communicate with PCOS patients about their disorder, about their body, and is there a potential weight bias included there?
Thank you for the question, Sasha. And the short answer is yes. There is the communication is key. One of the things we are taught as clinicians is to communicate better, but I can see both sides of the room. We have 20 minutes of a consultation, and we need to address everything. But that doesn't mean that we shouldn't be discounting what women feel about themselves, and we need to address it. Which means this is where the first part of the work with Sophie will be doing, and the last part where Mayar will be doing, to talk to patients to understand what is their experiences and expectations about body image concerns in PCOS across different people of different ethnicity and classes of life. And also, Maya will be talking to the healthcare professionals across the world to understand how they address it. And this might help us put together some kind of a communication tool, a toolkit to help saying that these are things you should be saying to people, these are things you should not be saying to people. And as you are aware, there are several studies that's shown many, many times that women with PCOS are dissatisfied with the way they're treated or they're being communicated. So this is an area that we are very keen to address.
Dr. Piltonen, what's the message for clinicians from your data? And also, it looked like both your controls and your PCOS people, the average age of death was early 50s. Was that surprising? Or
Yeah, but thank you for the question. First, I'm going to answer the last one. So yes, this is a young cohort still. It's a cohort of women, and this is what we have available because, of course, the register-based, data set just run as far as they run. And then on the other hand, you can't take very, early days because, you need to also make sure that the diagnosis were proper. So we have identified the people between the years 69 and 19. So between that time period, women who have been getting their diagnosis are here, and the oldest one was 90, but there were just a couple of women that are older than that. But the mean age is actually fairly young, thinking that, these Rotterdam criteria, for example, and the awareness of the syndrome has just, it's actually quite young in that sense. But of course, as the data will accumulate, we will also get to see, when this population is getting older, whether this difference will remain. About your first question, what is the message to the clinicians? I think this really calls for acknowledging this syndrome. I think this is the difference between the controls and pieces was 1 year for their life, or kind of their between the age of their death on average. And I think it's just, I think we need to acknowledge that this is actually a burden, health burden. It's not just a reproductive problem, and in many cases we deal with the reproductive problem and then the women are left alone. They are not considered, after that any, in any case, a particular, case in a healthcare system. So I think my message is that we need to look beyond, because the reproductive outcome is actually really good. We can manage that, but I think the most important and the difficult part is how that we can control the lifelong health for these women, and how to support them to achieve the best health that they can get, and of course it's a multidisciplinary effort, and of course we need to put some efforts on the resources, and then I'm also calling for more resources for the research.
Can I add to that? Thank you, Prof.
Mike.
Just a quick point on the acknowledging point. In our medical schools in the UK, in 5 years, a student gets 45 minutes of teaching on PCOS. 5 years, 45 minutes. And they're expected to know everything about PCOS. Second point, recently there was a study that came out in, I think it was in Nature. Over the last 20 years, of all the funding that's been given for all the different studies, PCOS got less than 0.5%. And we're talking about 10% of the women. Even if you go by the most conservative estimates, very little money spent on women. If you match it to a similar male condition, a lot more money is being spent. So that's probably the main thing. We need to acknowledge it, educate people more, and we need to spend more. Prof. Ricardo Aziz is here, and he mentioned a very important thing. We need more epidemiological studies. We need more population-level studies to understand why and what's happening. And I'm surprised as you are. Women dying at 50s, that's bad. That's really bad. So, thank you.
I had a question for Dr. Jayasinghe. This is Mike Menasher from Helio. I wanted to ask about this, if you had any more specifics on the post-cycle therapy. In this cohort, were you able to study what specific drugs or what specific therapy these men were taking, and could that help construct some recommendations in the future?
Thank you. That's a great point. We did analyze what they were taking. Sometimes they didn't know what they were taking, and I think that's that. But there is a mixture of what we call selective estrogen receptor modulators, which stimulate the hypothalamus to fool it into thinking there's not much testosterone, therefore telling the body, hey, let's make testosterone. Or something called human chorionic gonadotropin, which stimulates the testes directly and fools it into saying, hey, the body's telling me to make more testosterone. So these are the substrates. I think we're not there in terms of being able to, first of all, recommend this because there's no causality. But I think what we need to do, rather than jump to endorsing some form of combination which is on the internet and has been made without evidence, I think this deserves to actually a forensic investigation of studying the effects of both these type of hormone groups and how effective they are, and in what doses to make them safe for these men. Thank you.
Anyone else in the room have a question? Let me just double check and see if we got any questions online.
While we do that, Dr. Kempa-Goda, I was wondering, how do you think the stigma around PCOS and its association with obesity, how do you think that plays in to your findings?
Thank you for the question. Funny enough, just before I came to this hall, I went up to the Novo Nordisk stand up there, and I had a chat with them, and they've looked at almost every parameter during their various studies worldwide. They've never looked at body image. I was a bit surprised that even such big pharmaceuticals are not considering this as a concern. Obesity does play a role, But I think it's much more complex than that. There's a lot of societal pressures, peer pressures. I was just talking to one of my colleagues yesterday, and there's a generational shift. When we are looking at late teens, early 20s, it's much more the social media that's causing that body image concerns. But if it's more the late 20s, early 30s, it's the families, because you're like, oh, you don't look good in yourself, that means the thing. And there's a lot of social, cultural interplay that play into place, which is why we are looking at that aspect very detailedly with Sophie doing the study. Other than obesity, we also need to acknowledge that obesity may not be the only thing, because there's lots of studies which shown that excess hair that women get with PCOS also affects the way they look and feel about themselves. So we can't just blame weight as one of the main reason for everything. So yes, obesity is a main factor, but it's not the only factor.
Great, thank you. Great. So we do have a few questions online. The first one is from Kristen Monaco at MedPage. This is for Dr. Kempegowda. How exactly can clinicians support patients struggling with PCOS and body image issues?
Thank you for the question. Sorry, who asked that question?
It's Kristen Monaco, reporter with MedPage.
Okay, thank you for the question, Christine. Very good question. And this is where we will be going eventually, which asking clinicians all over the world to understand how they are doing. But if I may share observational data, when I've spoken to patients, the first thing they say is even acknowledging this is a problem for them is a first step, and they feel a lot more happy saying that, okay, somebody's looking into it. Secondly, most women, at least in my consultations when I do not need to be referred to a psychologist or they need to be acknowledged, and they need to be provided help. So these are what we call as non-pharmacological treatment without any medicines. There are medicines which can work too. It depends on which one we're talking about. If we're talking about weight being the predominant factor causing the body image concerns, there are weight loss medicines we can consider. And if it's excess hair, there are medicines. Unfortunately, neither of them are licensed for PCOS, but we can use it for non-licensed purpose. But eventually, we will look forward to developing some evidence to do this. But the first step is acknowledging it, supporting and listening to what they think needed, and despite all the best measures, if it's not working, then we start looking at medicines.
Perfect, thank you. So the next question is from Mitchell Zoller at Medscape, and this is for Dr. Jayasena. There's a few questions, so I'll probably let you answer one at a time here. Do you and your associates plan to run a controlled prospective study of PCT, or would this likely get run by a different group of researchers?
Thank you. Yes, I mean, clearly the thought has, I think whether we do it or I'm aware that there are other groups who are interested, I think it needs to be done. And but there are broader, there has never been any trial done in this group. And this could be, you know, in every shop, every workplace, every school, there are men and boys taking this, exposing themselves to risk and risk to society as well. So we need to have funding, and I hope very much, whether it's us or another group, this gets done within the next few years. Yeah.
Okay, great, thank you. Next question is also down the road, if this can be confirmed as a safe and effective treatment for AAS withdrawal, which types of clinicians do you envision providing this treatment? Do you think this will evolve into a treatment mostly administered by GPs, by reproductive medicine specialists, or by endocrinologists?
Yeah, that's a great question. And I think it's important to come back to the fact that this is an addiction and this is not just an endocrine problem. If we look at, say, other forms of substance use, such as alcohol or opioid addiction, certainly in the UK, this tends to be devolved into communities because people sometimes can't access or are afraid or suspicious to access big bad endocrine centres. And so so I would love these men to actually access a brown paper bag and actually have access, you know, to actually community pharmacies and actually projects in their local area, but then have a triage so that clearly if they have ongoing, so this therapy or future therapies could have the chance to help these men survive for at least 3 months, with behavioral therapies as well to address underlying body image disorders. But of course, that helps them survive and stay off. And then what? Then there's going to be some people who still don't recover, and who may, need to transition over to specialist care. So that's how the model would work. You need a combined model that involves the community, in my opinion.
Okay. One last question from Mitchell is, in general, where did the 613 men you studied obtain the agents for PCT? Are these purchased online or from other sources? And I believe you suggested regimens for administering PCT are found online. Is that correct?
Absolutely. There is an enormous subculture and community. You can, I believe in the States it's a felony. In the UK it's a Class C drug, so that it is criminal to distribute, but they've accepted that it would not be criminal to personally consume it. So you can actually buy this online. You can use PayPal. You can buy your Viagra at the same time because your erections are going to go, and you can get that expedited delivery. So there is an incredibly refined distribution network all over the world, and there is a vacuum of medical advice on how to help them, a vacuum. And these are, I didn't say this, but some of the most vulnerable in society. Half of these men have suffered child abuse. These men tend to be in work, but in low-paid manual work. And so they're just trying to get on in life. And this is a manifestation of their suffering. So there is something we need to address, but there's an incredibly sophisticated online network that is influencing, whether we like it or not, our healthcare system and our social care system. Thank you.
Thank you. Okay, that's all the questions that we have online for now. Anyone else have a question? All right, I think we're all set.
Thank you so much to our speakers and all the journalists who took the time to join us today for this fascinating discussion. And we're so grateful to our three speakers. Your passion for these subjects is really clear, and we appreciate you sharing with us. As a reminder, the recording of today's session will be available on our website and our YouTube channel, as well as the live streaming channel in the coming days. If you have additional questions or would like to set up an interview with our presenters, please feel free to reach out to us at media@endocrine.org. Thank you so much, and have a great day at ENDO.
Thank you. Well done.
Thank you, ma'am.
Okay.
I'd like a copy of the slide. No, Ricardo is it.
Hi.
Good.
I've met you in.
Thank you. If they said anything bad about me, it's not true. It's all good.
Well, Steve Franks does a good impression.